malleolus is right here. Lateral malleolus is right here, and you have very easy to find malleoli, so that's a good thing.
Yeah, you can't miss these.
Nope. You know what? I'll tell you what. Go ahead. Let's take shoes and socks off of both feet, and then I'll point things out for both sides so that you guys don't have to move around and walk around.
I know, right?
No. Go ahead. Here, pick this up and put this leg here, that leg here. I'll use this over here. So, here's your landmark on the lateral side, the lateral malleolus, correct? So if I want to find the anterior talofibular ligament, or the ATF, we just go anterior from this. I'm on it, okay? Now, the pain might be somewhere in that vicinity. It might be closer to the malleolus, it might be closer to the talus, but you just kind of poke around and find out where their pain is. If you want to find the calcaneofibular ligament, it's directly underneath, inferior, boop, I'm on it. Okay? If I want to find the posterior talofib, boop, posterior. All right? So it's anterior or posterior, and then directly below or inferior. And that's the ATF, which is the first one that is put on stretch and the first one injured. Second one injured is the calcaneofib, and the last one is the posterior talofib, PTF. So those tend to be very easy to find. Now, can you guys see deltoid, or the medial malleolus and the lateral malleolus? Medial and medial, I mean. So to find the deltoid on this, you simply drop straight down and then fan out all the way underneath it. That's the deltoid ligament. Good? Deltoid. Go here, drop straight down, and then you just fan out underneath it, kind of like a U. The tibiofibular is up here between the tibia and the fibula. So if I were to get right where these 3 points meet, they're anterior and posterior to that. So if I push up here, I'm spreading those bones apart, and that will create pain. All right, so that's where those ligaments are located. It's easier to try and palpate around the anterior, kind of tough to get to the posterior tibiofib, but if there's pain there, it's because of a lot of stress and damage, and they're going to be in a lot of pain, and it's going to take a long time for that to heal. So it's not as though you're going to miss it, let me tell you. What's the next thing listed? Achilles. Okay, so the Achilles is pretty hard to miss. You simply come back here, you just go and take a hold of it, and there it is. Now, if you guys can see, and this, you have great angles to demonstrate. Here's the Achilles. I roll around to the side of the Achilles, and then I don't run into any major structure until I get down here. So if this structure is ruptured, you don't come into, you don't run into anything until you get down here. So that's like this much space that is going to be missing if you're going to be comparing. So if you were to have him on his stomach, which we'll do in a few minutes, if the Achilles ruptures, the one that's ruptured just doesn't look, well, it does, it looks, but it is absolutely flat, whereas the other one has a nice ridge to it. Okay, so it's again real obvious to tell if there's an Achilles there or not. First of all, you can't get your fingers on it. Second of all, you just look, and there's nothing there. The perineals, longus and brevis. Those two muscles come from up here. One's a little lower. The tendons come down behind here, come underneath here, and they do this motion, up and out. If I go this direction, the opposite direction, I'm stretching them. All right, so I'm going to have you pull up and out in a second. And what I want you guys to do is look right in this area and see if those tendons pop up. So pull up and out. No. Push against my hands. No. Push up and out. Up and out.
Up?
No, just don't go like this at an angle.
Oh, just okay.
Yeah,
Just
yeah,
like
sorry.
that.
Do you see it?
Yeah.
Just push and stay there.
Oh, yeah.
Push and stay there. Just push, stay there, stay there, stay there, stay there, stay there, stay there. Okay, relax. Okay, so you see those?
Yeah.
And the motion they provide is what he was just doing, up and out. So when we sprain ankles, all right, and we fall on our ankle and go this direction, guess what gets pulled along with those ligaments? Those perineals. You felt that, huh? Okay, so you can end up truly with a sprain-strain combination. Would we do anything any different treatment-wise? Tell me. Tell me.
No.
No, it's the same treatment. So if we identify it as a sprain and it's a combination sprain-strain, who cares? It's still going to heal. We're still going to do the same thing treatment-wise. The posterior tibialis arises from the back medial portion of the tibia and then some parts of the fib, and it comes down the back side, comes behind the malleolus, the medial malleolus, and goes underneath, and it pulls up and in this direction. Okay, so go ahead and pull up and in. Can you see that tendon?
Yeah.
Maybe not quite as obvious. Let me see. Go ahead and do it again. Come on. Yeah, right in through here. See this right here? Okay, so pull up and in. See this one right here? And then it ducks right down here. I can feel it more than you can see it. All right, but that's what I want you guys to practice today. You're gonna do some hands-on. All right. So the perineals, evert, and the posterior tib inverts. When they assist the gastroc and soleus, when you go up on your toes, those muscles help you from doing this when you're up on your toes. Okay, so they come down here and help stabilize. And that's how you can stay on your toes and not wobble all over the place and fall over. Okay? Perineals and posterior tib. So, go ahead. Was there a question? Okay. So I need you to know where those are located and what their action is. Okay? So the perineals are on the outside, and they do eversion. That's what their motion is. And the posterior tib is on the inside, and they do inversion. Or it does. Tibialis anterior is located where? Anterior of the tibia. There you go. There you go. It tells you exactly.
Right.
All right? So if you were to put your hand right here in this meaty spot, and go ahead and go up, straight up and down with your foot. And relax and point. And then up. And can you see a little bit of, yeah, you guys can see this one here. There it is, there it is, there it is. There it is, yeah. Okay, so here it is right here. That's the anterior tib, and then its tendon comes all the way down and attaches down here. In fact, go ahead and pull both sides. Can you see that tendon? All the way down here and attach. You can follow it all the way
It's gonna
down.
be easy to do, Claudia. I'm gonna have a tough time with her finding her.
So the anterior tib or tibialis anterior will dorsiflex the foot, and if they're forced into plantar flexion, it can strain that. All right. Gastrocnemius. If you don't know where that is, tell me. I'll come over and smack you. Where is that? The gastroc is the calf muscle. It's the round one, okay? And when you've got somebody that has really defined calves, as they go up on their toes, you can see both heads. There's two heads, and you can see both of them. They make this little kind of, what, W?
There was a hurdler in here today who had a hamstring pull, but when he did, oh my goodness, that definition was just incredible right there. It's like, whoa, I can see
Now
that.
you know why it's nice to work in a place like this, because you go, oh my God, look at that muscle. Oh,
Yeah.
that's what it's supposed to look like.
Yeah.
Oh, mine never
Mine
looked
don't
like
look
that.
yeah.
You see yours?
Yeah.
Ooh, stand up here. Face these guys, and go up on your, face them. And now go up on your toes. Yeah, you can see.
Right.
Okay, now turn around the other direction. And you guys can. Okay.
Yeah.
All right, and so what does the calf muscle do? What direction, what motion does it provide? Plantar flexion, you just saw him do it, okay? So how do you repeat that? You plant your foot on the ground and go up on your toes.
Like
So
a ballerina.
plantar, huh?
Like a ballerina.
Yep, yep. All right, so now we go to the actual tests themselves that will tell us how to evaluate for these. So when you do plantar flexion, you're testing for the gastrocnemius and soleus, okay? When you dorsiflex, what are we testing for? What provides that? Anterior tib, anterior tibialis. Now, if I'm going to test for these, now you have to think back in from when we talked about this, some of the, let's see, what chapter was that? 16, therapeutic X? Or no, 13, evaluation of injuries. If I'm going to evaluate the anterior tib, or the gastroc, I don't care which one, let's say the anterior tib, I am going to tell that they have an injury based on what is it that tells me they have an injury? So I'm going to pain where?
Wherever they're injured, wherever.
And how do I find that?
Ask them.
Palpate. Ask them, but you palpate. So palpation is one method.
Ask them to put one finger.
Yep, and you've heard that how many times? All right, so I can palpate to find the problem. How else can I find the problem? What else would cause them pain? If they did what? Exactly. If they use the body part, contract the muscle. So if I'm testing the anterior tib, what motion would that be? Say it, you got it, dorsiflexion, okay, so it's contract the muscle. Or if I do what else to the muscle?
Stretch it.
Stretch it, and that means it has to go in the opposite direction. So if the anterior tibialis dorsiflex, then to stretch it, you relax, and I have to go the opposite direction to stretch, all right? So it's just opposites. When you contract, and then you decide, okay, I want to stretch it, you let them relax, and you go in the opposite direction that they just went. All right. Now, when you're testing for the perineals and the tibialis, and you're doing inversion, eversion, sometimes you have to actually direct them, hands-on direct them, because they're not going to know what inversion and eversion are, and they don't know. Just like when I was trying to say go up and out, and he went up and then out. So then I said, no, go at an angle.
Right.
Or I might have to say go this direction. Or I might have to actually take their foot and say, oh, okay, I want you to go this direction. So it makes it easier. Because they won't know the terms that we talk. All right, so they won't relate to that at all. All right, inversion. What muscle is going to invert the first of all, which direction is inversion? Okay, the sole of the foot, the soles of the feet look in at each other. In, exactly. What muscle controls that?
Perineals. Oh wait, no, fully in. Ha ha ha. No, posterior tib.
Okay, the posterior
I
tib
was thinking of what was
sits
stretching it.
in the back, behind here, and it comes, yeah. So it's the posterior tib, and to pull your foot at an angle out,
That's the
eversion
perineals.
is the perineals. Okay? So those are the muscles that control that motion. Now, Taylor tilt is going to identify the ligaments at the ankle. You get them in 90 degrees, and if you want to check the ligaments on the outside, okay, on the lateral side, the ATF, CF, PTF, you're going to get them in 90 degrees. You're going to take a hold. I'll do it over here for you guys first, and then I'll come over here for you guys. You're going to take a hold of the calcaneus and the forefoot, get them at 90 degrees, you relax, and you simply tilt and see how far it'll tilt. Okay, this direction, all right? Same thing, 90 degrees, you relax. I've got the heel, and I'm tilting the heel and the forefoot. And can you see how much stress is being put right here in this area? And if it tilts and they say, ah, and then I check the other side and that doesn't tilt very much, then you got a positive test. So that was Taylor tilt inversion.
Inversion.
If I want to check the deltoid, I will do Taylor tilt eversion, the other direction. Here's Taylor tilt for you guys over here, eversion. Now that doesn't have quite as much motion to it, so you don't get as, as
What
much
does the inversion do?
Gets in the way, right?
Yeah.
I know, but eversion is
and the
deltoid.
deltoid's pretty strong.
What was the inversion one?
All right, do you have those?
What was the inversion one for? The
ATF,
oh, okay. There you go.
CF, PTF, all three of them. And if you get an Taylor tilt inversion that you think, ooh, that's not very good, then you can test and do the anterior drawer. All right, so the anterior drawer is 2 down from that. So I want you to scoot forward so you can bend your knees. I'm going to take his heel, put it in my hand, let his foot relax on my forearm. I'm going to stabilize his lower leg, and I am simply going to do this. Okay, I'm going to open the drawer. And I'm going to look right here to see if there's a dimpling or sucking in of the tissue. Now, I'll show you guys over here. Take a hold of the heel, stabilize, and I'm looking right here, and I'm simply pulling forward. He's got a little bit, not much. Was that painful? No? Good. Oh, let me tell you, if that's a positive, and I will guarantee you, if they have a positive test, you will get one shot at this.
Yeah.
Because this is
Bam.
painful.
Yeah,
And
your
they won't
shots
want
do
you to do it a second time. So you better make sure, if you do it once, you do it right. And you just get a good yank. And make sure you
Let me do it
pull
one
hard
time.
enough. Don't be nice. I'm not trying to make friends.
Sometimes. Sometimes you want to make friends.
You know, it's not as though you want them to be in pain, but you have to find out what's going on. So anyway, now, Kleigers will test, now, so Taylor tilt inversion will test for ATF, CF, and PTF, correct?
Yeah.
And if you get a positive, you do the anterior drawer, which tests the same ligaments, ATF, CF, and PTF. And the amount of movement you get will tell you how bad the problem is. These tests, Taylor tilt and anterior drawer, Taylor tilt inversion, eversion, anterior drawer, and Kleigers all test for stability. Ankle stability, joint stability. All right? Joint stability. If they're unstable, they're beyond you, you send them to a doc. If it's a grade 2, 1 or 2, you can deal with it. It's going to take a little time, but you can deal with it. Kleigers, go ahead and scoot back now, will test for deltoid as well as a high ankle sprain. Okay, so you're looking at the anterior tibiofibular, anterior posterior, but usually the anterior tibiofibular ligament. So the deltoid lies down here underneath the medial malleolus. Anterior tibiofib is up here, posterior tibiofib is back in the back behind the two. So you're going to stabilize, and you're going to push the foot up and out. Kind of rotate it up and out, okay? So I'm going to stabilize, and I'm going to push up and out. I'm going to push hard, up and out. So when I push out, it's putting stress on the deltoid. When I'm pushing up, it's shoving that talus up into that joint mortise that we talked about and pushing the tib and fib apart. And if you push up and out and they go, ah! You ask them, where did you feel that? And they might look at you like you're an idiot. What do you mean, where? It hurt. But usually they'll be specific. Oh, you know, they might point down by the deltoid, or if they're up across the top of the ankle, then chances are you've got a high ankle sprain. And oh, bummer for them. Now, you can probably already guess that because in your hands-on evaluation, you were probably up top. You're checking around and you got up top, and when does it, you know, at some point you're going to poke around up there and there you're going to find out that it's pretty tender. And when they have tenderness up across the top of the ankle in between the malleoli, bummer. Okay, that's a long haul. That takes time to improve. So let me show you what it is I do for an ankle evaluation. All right? So if they tell me it hurts on the lateral side, I'm simply going to start on the medial side at the bone, and I'm gonna get up on the bone. I'm not gonna get down low where the ligaments are attached. I'm gonna get up high. And because what am I looking for to begin with? What am I testing for? First thing I wanna check is,
Pain.
I know they're in pain, they came in to see me.
Okay.
Dislocation?
What is this?
Bone.
Oh, first thing I'm checking is bony tissue.
Okay,
Okay.
first thing I should
So
start-
I put my finger up on the bone and see if they have pain on the bone, okay? And then I walk up the bone a little ways and see if they have pain up there, and then I'll tap on that bone a little bit. I'll do the same thing over here. Now, they've already gotten a little bit of my touch. Then, no, don't. Then I'm gonna come over to this bone, I'm gonna do the same thing. Okay, tap on it. If they tell me, ouch, 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 what's that? What am I thinking? Or just you're right, not stress though,
Just a
Fracture.
a fracture of some sort. I'm gonna come up here and I'm gonna squeeze up high. It's a squeeze test, that's literally what it's called. And you're squeezing the two bones together to see if the pain, the force radiates down to a spot down here. All right, that could indicate, you know, when you have any kind of motion that travels down a bone, if there's a fracture site, it'll hit that fracture site and they won't like it. The next thing you do is the bump test. Now, this one you have to be very careful. When I do a bump test, I take their foot and I protect it and I hold it while I'm doing this test, and I hold it into about 90 degrees. And then I do this. Now, what's that create? Vibration, which would show me what?
Fracture,
It goes to the fracture site and creates discomfort and pain.
and you hope that they don't
Okay.
hit you.
Now, you know what, and they usually don't, because honestly, if I think there's a fracture, I might not even bother with this one. I might just be sending them out already. If I don't think there's a fracture, I would do this. And this is the look I get when I do that, okay? You ready? You don't have to show this. I do this test, and this is what I get.
that's good.
Or sometimes I'll get, ah! And then they'll stop, and they'll think for a moment, and I'll look at
Didn't
them,
even
and I'll
hurt.
say, did that hurt? And that, honestly, so many times I get this, do it again. Because they're not sure. They think it hurt,
Oh, but they're not
but it
sure.
really didn't. Okay, so they don't know. And so I'll just say, no, that was my answer. I won't do it again, because I already have my answer. It didn't hurt. If it did, they'd tell
Oh, they
me.
would have told her right away.
Yeah,
right?
they would have said something. But when they don't
But they don't
know,
know. Oh, okay.
so there's my
Let me
answer.
think about it.
Okay?
She's like, don't show this.
They're just surprised that you're winning.
They are. They are. They don't expect it. Now, watch his foot. If I don't hold it in position, and let's say it's one of the typical ankle injuries, and he's really gotten a good one, all right, it's a second degree, and he's in a lot of pain, watch what happens if I don't protect his foot into 90 degrees. Where did his foot go?
So well.
It went down here. Is that going to create pain and discomfort? Yes. So you don't want it to do that. So you protect it, and then you get your answer. Okay? So you have to hold the foot in place when you do that bump. Otherwise, you're going to get a false positive on that. You're going to bump, and the foot's going to wiggle all over the place. It's going to stress those ligaments. They're going to cry, and then you're going to think, oh, they got a fracture, and you're going to send them out, and they're going to come back. Nope, no fracture. So the protection of the movement of the foot is very important for that test. All right, so the next thing I do, I've already palpated, I've done a squeeze test, a bump test. Next thing I do is I literally put my finger on the malleolus, and I go, do you have pain here? Yeah, yeah. Do you have pain here? A little. Do you have pain here? No, not really. Then I walk up this direction. What am I looking for when I go up here? What's up here? The perineal tendons. All right, so I want to see if those are involved. Now, they might be involved just down here as they turn the corner and on their way to their attachment. If so, they might tell me, yeah, it kind of, they'll tell you, you know, it just hurts kind of down here. Does it go down this direction? Yeah, a little bit. Okay, well, down here is not a ligament. Okay, ligaments are all up in here. Then I'll go to the medial side, and any pain here. Okay, so I'll go to the medial side. Pain here, deltoid? No. All right, good. That's a good thing. So now I've just tested the 3 major ligaments and the ligaments on the inside, the deltoid. I've tested for fracture. Now I want to see, well, let's see, what kind of range of motion do you have? So I'm going to say, pull your foot up into, pull your toes towards your knee. If I say dorsiflexion, they won't know. Okay, and I want to make sure it's pure dorsiflexion, plantar flexion. So I hold my hands here so they don't, wobble all over the place. Now point your toe, okay, and go up and down. And what I want to see is what is their range. What can they do? If they can only go, from here to here, then that tells me a lot. All right, then I passively say, okay, tell me when it bothers you, and tell me when you feel it. And then I might go to the other side and compare if it's real minimal. Then I'll do my Taylor tilts, inversion, eversion, and see if there's any pain. If I get a positive and I'm suspicious about joint laxity, I might do an anterior drawer for the lateral side, for the ATF, CF, and PTF. Or if they, and I'll also, after I've actually palpated, I'll also come up high and go, do you have any pain up here anyplace? And if they say, oh, yeah, or if they're really crying, then I'll do a Klager's and see if I get a positive. All right? That's pretty much it. Now, if it's not that bad, I will do resistance, and I'll go, okay, pull your foot up, straight up. Come on. Come on. Good. Push straight down. Now I want you to pull up that direction. Okay, good. Now do it against my resistance. No. Up that way. Good. And push down and in. Against my resistance. All the way down, down. Good. Then I'm going to have them go up and out this direction. Up. Now when they go up this direction, this is usually the way they get injured, and so I'm careful when they do that. All right, if they've already indicated that they can't do that motion very well, then I probably won't provide resistance. But if it's a grade 1, then I want to see if they can handle resistance. If they can't handle resistance, what won't I do with them? What will they not be able to do if they can't handle the resistance I provide with my hands?
Weight bearing exercise.
What?
Form in their sport.
Yeah, they can't go back.
Oh.
All right?
You suck.
So I want to see if the resistance I provide is a big problem. If it's not, then, all right, let's have you stand up on your toes, stand on your feet. Do a pirouette? No. All right. Go feet parallel and go up and down on your toes. Okay, good. Now I want you on the uninjured side, lift one foot. I don't care which one's injured. Lift one foot and go up and down on your toes. Now on the injured side, put your foot back down, up and down on your toes. Can they do that? Okay. Okay. Oh, you're a basketball player. You can't do a layup. Sorry, you can't play. Okay. Or a volleyball player, or a, if they can't get up on their toe, just think. Give me a sport that. Explain to me what sport that can I send somebody back when they can't get up on their toes. They can't run. Okay.
Chess isn't a sport.
They could play tennis.
Chess isn't a sport.
Archery. They could do archery. Even swimming. Everyone thinks, oh, that's all arms.
No.
They have to push up off the wall.
Bingo. They have to get off the wall. Well, diving, we're not talking diving.
I know, but I'm just like
Yeah,
thinking
but
like,
you're right.
oh,
Especially diving, because they go up on their
Like it's
toes a
not a
lot.
sport.
So they do lots of pirouettes. No, just kidding. So then I would tape them up, and then I would put them through the paces to see what they're able to do, if they're able to do their sport-specific activities, and if I'm in a pinch and I'm in a game situation, then we'll if they're able to perform, then we'd send them back. If it's in a practice day, I'd test them, and at this point we'd probably ice them and elevate them and protect them for the evening, send them home, and then bring them back the next day and see what they're able to do. And cross our fingers, it's better than what it was when I looked at it the first, the day before. So if it's not too bad, and they come back the next day and it's even, it looks better, then they're probably playing. If it's a grade 2, they're out for a while, all right? All right, so questions about that?
What is the Thompson test?
Oh, I'm sorry, I left that one out,
What is
didn't I?
that one test for?
All right. I don't have I've got Thompson test. Oh, I left off half the page. All right, Thompson test is pretty darn simple. Lie on your stomach, please. with your heels hanging off the edge of the table.
Nose in your shoes.
All right.
Well, they'll all be in order, so then.
Evan, scoot forward. So, take a hold of his calf, the belly of the calf. Okay, kind of like this. All right. So, what's that attached to? The Achilles, which attaches to this bone attaches to the what? Calcaneus, the heel bone. So, what I'm going to have Evan do is squeeze the calf. You guys look at the heel. Squeeze the calf. And let go. Just squeeze it and let go. What did it do? It moved. Didn't it move?
You have no sensation.
Go back.
Squeeze hard. Knead that bread.
But be gentle.
Okay? All right? Are you in the belly of the muscle? Move my way just a little bit. Okay, now squeeze. Okay. A little bit more. Okay? So, if you question whether or not the Achilles has been ruptured, there's two very easy things you can do. The one thing is literally look at it. Because if this structure right here goes, there's nothing on there until down this far down. And it will look really, really flat compared to this one. Okay, we've got what, at least an inch of space, all right? But that's the Thompson test. So if you think, oh, I think there's a chance you might have ruptured, although you're pretty darn sure, because you look at it and go, whoops. Then all you have to do is squeeze, and it does not move. If it doesn't move, it's not attached. That's your answer. It was a positive Thompson test. Not something you want to have to tell them. Okay? What's the next one? Lower leg evaluation. So now we're going to evaluate.
So what happens like when you squeeze on the calf muscle? Because I wasn't able to see.
Lay on your stomach.
Oh, this goes like this?
Your foot will move.
Really?
Because, yeah,
Here,
it's pulling
watch.
on the tendon. It'll move.
Watch his feel.
Ah,
Okay?
Yeah.
It moves.
okay. I didn't feel that movement.
All right. Medial tibial stress syndrome is also known as shin splints, all right? And we talked about shin splint being the catch-all term of any pain between the knee and the ankle, but that's not the case. We have to be able to discern what is the difference between what pain, where is the pain to begin with? So, when I'm testing for shin splints, I'm usually sitting off to the side here, but I'll sit in the middle here so you guys can all see. Go ahead and scoot back. A little bit more. Right there. So what I'm going to do when I, excuse me, I'm going to simply walk up the bone. And I'm going to say, does that hurt? 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 And with a shin splint, I'm going to get yes, 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 all the way up the bone. Okay, a general pain is what it is. And if they say yes, oh yeah, that hurts. That's the spot. That's the spot. It really, really isn't, because the spot that truly is in pain. If you put your finger on the shin bone itself, the tibia, and then go around the corner to the back side and dig in, that's where their pain is. Okay? So let me show you guys on this side. So here's his tibia. I can feel the edge of the bone, and then I can just crawl right up there. And I can get in and behind. And I'm telling you, when you do that, if they have shin splints, do we have anybody here that has shin splints? Like, no. If they have a true shin splint, a good shin splint, all right, good meaning it bothers them, they will levitate. Their butt will come off the table. It'll bother them so much, and then they'll know, oh, that hurts. It's not the pain on the bone. They're getting a little bit of referred pain that kind of comes around the corner. But the pain is around the corner on that soft tissue where that posterior tib and this tendon are located, and the fascia that helps hold that up against the bone. All right? Now, the posterior tib comes down here and attaches right down here on the navicular, which is what we talked about on Tuesday, correct? So the problem they have is what that causes shin splints? What?
Lack of support in it.
Arches?
lack of support in the arches. So when the arches give too much, okay, it yanks on that tendon, yanks on it, yanks on it, yanks on it, and pretty soon it goes, cut it out! And they are painful here, but the problem is down here. So they need arch support. Whether you tape them, give them padding for their shoe, or tell them go buy an insert for your shoe, whatever. And some people have such bad foot structure that they flat out need orthotics. But these days, how many people that we deal with have insurance and can insure and can afford that? So, or can just flat out pay for it.
So the taping for the shin splints really doesn't do much for them?
Not really. You know what? It does. It helps deal with the pain, but it doesn't deal with the problem.
Isn't it kind of just temporary?
Yep, exactly. And if we can get them shoes with good support, then that probably helps a lot. Now, how many of you have purchased a pair of shoes recently? And did they have great arch supports in them?
Yes.
Okay? So if, whoa.
A pair of hiking shoes, so yes.
Okay,
Toe-
good,
toe
good.
box and
Not
really
Vans.
good.
So I
That's
would
what I was gonna
suggest
say.
from now on,
Not in
when
my Vans.
you have Vans? No.
I do.
Okay, those are flat.
Yeah.
Nada.
Those are not good.
Okay, so it really depends upon what you purchase. Some shoes
I
have,
was like, none of my Vans.
have good supports. A
Speaking of
lot of
Vans,
shoes
shut
don't.
up.
Okay, they have nada. So it's a good idea to,
If we're like
and it
that
all
big.
depends on what it is you're doing.
Freaking big
In
birds
here,
on them.
guess what's underneath this?
Cement,
Concrete.
concrete.
Okay, so we're on concrete all day long. All right, so man, every time I buy a new pair of shoes, I've got a new pair of inserts, and they zoop in my shoes. All right, so make sure that I've got good arch supports. All right, what's the next one? Acute compartment syndrome. Okay, that acute compartment and chronic compartment, I told you, it's not something you can actually get your hands on and test for. It's more, they explain what's going on. Now, acute compartment, you can actually observe and maybe see inflammation and that shiny skin stuff. You know, when the skin is stretched beyond its normal ability, you know, its level of elasticity, it will have that shiny sheen to it because it's stretched beyond belief. And the pain only gets worse, and that's when you say, okay, you gotta go in. But sometimes they don't, they deny it, or it happens when you're not around. So if somebody gets hit in the lower leg, I always make sure I tell them, look, if you go home and this pain gets worse, and gets worse and gets worse, you get in tonight. Don't wait until tomorrow, which they won't be able to because the pain will be too intense. But the sooner, if that is the problem, the sooner they can get in, the better, and the less pain they'll have to deal with. But it'll still be painful. Chronic or exercise-induced compartment syndrome is real. It hides very, very well because they stop their activity and it goes away. And so usually somewhere along the, you usually don't pick it up for quite a while. And then somehow they say something, or someone else, one of their running mates says something, or teammates, and then the light bulb goes on, or the little piece of dynamite goes off, whatever, however you want to put it. The brick falls out of the sky and hits you on the head. You realize, you know, it's not a shin splint. We might have a compartment syndrome thing going on here. Question?
Does the drop foot always
No.
go with
No.
that?
It only deal when there's anterior compartment problems, because that's where that muscle is located.
Oh, okay,
Okay.
couldn't you just go with them outside and watch them exercise and then see if their
Yep.
foot drops? But
It depends on
okay.
what compartment is involved,
Oh, okay.
okay? So that's why you have to kind of tune in. Because some of these things can be very, very subtle. And it takes, sometimes for some of it, it takes a while for you to put all the pieces of the puzzle together and the picture to, you know, float up in front of your face and you just kind of go, whoa, smack, smack. There it is. All right. All right, last couple. Okay, stress fracture. Remember when I did compartment syndrome? No. Remember when I did palpation for the tibia? And we got this
General pain.
ouch, 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 ouch. Okay, so for a stress fracture, you're just gonna go, okay, does that hurt? No, 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 no. Yes! Okay, so you keep one finger on that side and you go, and they go, no, 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 no. You go back to that one spot, yes! And nothing else hurts anywhere else. So there it is. There's a hint. Okay?
Yeah, you did that out loud.
Or they might, or they, it has to be louder. Or they just might say, ouch. So it's literally what I have written there. Point tender, one spot. All right, you're looking for point tenderness, and whether it's their shin or whatever bone you're looking at, it's point tenderness on one spot. But it's easier to find it on a long bone because you can move along the bone and then get to that one spot and zoop, there it is. Homans. If there's a chance, this athlete comes in and says, oh wow, I woke up this morning, my calf was just killing me. Really? Well, what did you do last night? Oh, nothing. Did you get kicked? No. Did you jump? Did you run into the coffee table? Did you wrestle with your cousin? I swear I've heard that one. No. And there's no mechanism, there's nothing. What you can do is, okay, scoot forward, just so your heel's off. Have them relax, and all you're going to do is this. Passively dorsiflex the foot. So you're putting stretch on the gastroc, right? You're stretching the gastroc. And if they say, ow, there shouldn't be an ow involved with stretching the gastroc. But if that really bothers them, you've got to send them in because they may be dealing with a blood clot. And if that blood clot cuts loose, what can that cause?
Stroke.
Yep. Death. Okay.
Ultimately.
Worst case scenario, death. So we actually had an individual that came up with a positive Homans last semester. And our team physician looked at him and said, yeah, you got to go get this looked at just to make sure. And they did, and it was negative, which is okay. But if it wasn't negative, if there was something wrong, then, yeah, whole bummer. So, so if something's going on in the calf and they're in pain, and all you do is provide a stretch, and that makes it worse, something's wrong. All right? Unless they tell you, yeah, I jumped for a ball and I heard a pop, and then there's a mechanism. Something's going on. And if you palpate and poke around and whatever, and they contract the muscle, but none of that is positive, and all you do is stretch that thing, then yowza, get them in and get them looked at.
So is it painful because once the muscle contracts, it squeezes in the vein?
Mm-hmm. It's putting pressure. Yeah.
Okay.
Yep.
So
Exactly.
it's actually the vein that's in pain, not necessarily the muscle.
Yep.
But you feel it like
Yep.
like if it were on the muscles, yeah.
Is inflamed due to the clot.
Mm-hmm.
And then like the muscle
Large-
contracts,
and larger
so
than it normally would be.
squeezes in it.
So you just tell them, you go in today, go get it looked at, call your doctor, tell them, that and I mean, they can say, my trainer looked at me, which a lot of doctors' offices will go, oh, ho hum, whatever. But, like in the case we had here, our team physician looked at them. And so we use that. Just tell them our team physician looked at you and said they want you to get looked at for blood clot. And if they have no one available, then go to the, go to the ER, go to the, county, go someplace. Because, once you walk in the door and say, tell them, I think I have a blood clot, they have to take a look and verify that you're okay. Of course, these days, sometimes hospitals, it's getting worse and worse all the
Let's
time.
get started on that one. Should have brought that one.
Even if you tell them another doctor said to do a certain test, they're like, well, we do our own test.
Yeah, true.
I know.
So, okay, so that covers it, right? All right, so I expect you guys to practice this. Okay, so that's why
We
we
can
are
use
here
next week.
today. Tonight.